It's great to have you join us today for our discussion on ending violence against children, the role of community health workers. We'll be hearing today from Tom Davis, the Global Sector Lead for Health and Nutrition at World Vision International. Tom will share findings from a groundbreaking survey World Vision recently conducted of 412 community health workers in 4 different countries. The study explored the health workers' views on their roles in preventing, detecting, and responding to different forms of violence against children, an issue that is estimated to affect 1.7 billion children globally every year. My name is Dr. Henry Perry. I'm a senior scientist in the Health Systems Program at the Johns Hopkins Bloomberg School of Public Health and its Department of International Health. I am a physician with training in sociology and anthropology, and I've had a long-standing interest in community health, community empowerment, equity, primary health care, and community-based delivery of evidence-based interventions. I'm currently serving as co-chair of the Christian Connections for International Health Community-Based Prevention and Care Working Group. CCIH is an international network of approximately 150 Christian organizations and 20 partners, as well as a few hundred individual members, including me. CCIH's mission is to promote health and wholeness from a Christian perspective and provides opportunities for capacity building, networking, sharing best practices, and advocacy. In terms of the flow of our program today, we want to hold all questions until after Tom's presentation. However, please feel free to submit a question at any point and we'll hold them for later. To ask a question, click the Q&A button, type in the space and hit send. If you want to ask your question anonymously, you can check that box. This webinar is being recorded. If you registered for the webinar, you will receive a link from CCIH to the recording, or you can find it on the CCIH YouTube channel in the webinars playlist and on the CCIH website under resources and community-based prevention and care. Tom Davis is a dear friend of mine for many years. He's now the Global Sector Lead for Health and Nutrition for World Vision International. He has more than 35 years of domestic and international field experience in planning, implementing, and evaluating maternal child health and nutrition and education programs. And social and behavior change is his real expertise. He was the 2018 recipient of the Dory Storms Child Survival Recognition Award given by the Core Group. And in 2012, he received the American Public Health Association's Gordon Wyan Award for excellence in community-oriented public health, epidemiology, and practice. Tom was the original developer of the barrier analysis methodology and the education cascade care group model. Also joining Tom today is Elena Gaia, Senior Advisor on Ending Violence Against Children at World Vision International. Elena is a child rights activist with more than 15 years of experience in international development. Prior to joining World Vision International in 2016, she worked with other civil society organizations and United Nations agencies in Latin America, Europe, and Central Asia. She is passionate about making the world a better place for the most vulnerable children. So Tom and Elena, we look forward to hearing your presentation. Thanks so much.
Great, thanks so much. So can everyone see my slides now? Okay, I'm assuming so. So good morning, afternoon, or evening to you. It's really great to be with you today and to share some of what we've been learning in World Vision on the use of community health workers in ending violence against children. So over the past few years, we've seen increased buy-in from the global health community on the health sector's role in ending violence against children. But there have been some questions that have lingered on exactly what role should community health workers have in some of that work. So this pandemic of physical, emotional, and sexual violence now affects 1.7 billion children around the globe and results in an estimated cost of about $7 trillion per year. Violence against children robs kids of their childhoods, their dignity, their human rights, and their God-given potential. And if this violence, this level of violence against children continues, we really risk jeopardizing progress and losing investments made in child survival and development, not achieving the targets of WHO's global strategy, and not realizing the dream of universal health care. And so for the purpose of this session, we're defining violence against children fairly broadly as all forms of physical, sexual, and mental violence, neglect or negligent treatment, maltreatment or exploitation, harm or abuse, including sexual exploitation, trafficking, child labor, and harmful traditional or cultural practices such as female genital mutilation and cutting, and child marriage. So those, when we're talking about violence against children, remember this is in a pretty broad sense, but one that has a lot of different impacts on children. So this year, World Vision undertook a study for several reasons. One is that World Vision is running a global campaign that Elena will tell you about at the end, to end violence against children, that's now active in 75 countries. And that calls for every individual, every organization, and every sector to play its role. And we believe that the health sector in particular can play a pivotal role. Violence against children is often a hidden phenomena, and it's difficult to detect. And there's increasing political will and recognition of the health sector's role overall in this. And there's some evidence on the health workers and other health workers have in preventing violence against children, particularly through providing support to parents and caregivers. But there's little evidence on community health workers' current role in detecting and responding to violence against children. And further evidence is really needed on the potential of paid and volunteer community health workers in ending violence against children. Keep in mind that often community health workers are the first or the only healthcare worker that children may see, particularly in resource-poor contexts. And this potentially positions them as the front line of the health sector in preventing, detecting, and responding to violence against children. Now, there have been concerns in the past about the risks involved in mobilizing community health workers around issues of ending violence against children, which may be culturally sensitive, despite the fact that community health workers are really already intervening in other sensitive areas like family planning. There are also considerations related to the benefits and drawbacks of adding tasks to the community health workers' duties. And as I mentioned earlier, our results are based on a survey of 412 community health workers in Bangladesh, Kenya, Myanmar, and Tanzania. So what are the main things that we wanted to know through this study? Well, one is we wanted to learn about community health workers' current perceptions of the prevalence of violence against children in their community and their responses to it. We also wanted to learn about their perceptions of their current ability to prevent, detect, and respond to violence against children, the support that they receive and the support that they need, and any perceived barriers they had to doing this work. And also then to use that information to make recommendations to inform the design and implementation of interventions to end violence against children by governments, World Vision, and partners, either standalone interventions or ones integrated into other project models that we use. And here are some of the main things that we found in this study. One is 76% of community health workers reported observing at least one form of violence against children during the course of their work. That's a key finding, and it shows that community health workers are well placed to observe what is happening with children, despite it sometimes being a more hidden behavior. And also, over 74% of community health workers in the 4 countries studied perceived all forms of violence against children to be very serious. So they don't look at this as just some cultural thing or that they really don't need to do anything about. They see this as a serious problem already, so that's helpful for us. Community health workers in the 4 countries witnessed violence against children at a very high rate through their work, which helps confirm the existing country-level data about the prevalence of different forms of violence. Child marriage, harsh physical discipline, and verbal abuse stand out as the major issues across all 4 of the countries that we studied, with child marriage affecting mainly girls, and the other 2 issues affecting mainly boys. So we also found that community health workers mostly believed it was already part of their role to prevent and respond to violence against children, particularly in terms of counseling, prevention, and referrals, and that they display significant confidence levels about their existing abilities in this area. Over 60% reported taking action after witnessing abuse. And for whatever reason, Kenya's community health workers were overall more likely to respond to all forms of abuse, and community health workers from Bangladesh and Myanmar were less likely to respond. Community health workers were highly motivated to receive training on violence against children-related issues, but only 23% of them reported receiving violence against children-related training in the last 12 months. We do need to do better in terms of support systems of community health workers, since only 16% of them identified existing child protection groups in their communities. That's important since responding to violence does carry its own risks, and community health workers should have community support when they respond and refer children. Community health workers' violence-related work appears all the more remarkable considering that it's not included in their formal duties and that some of their barriers, which I'll mention in a minute, there's a clear potential to more intentionally consider the role of community health workers and counseling for positive parenting. This graph shows how they're responding, and note that counseling on positive parenting was their most common current response. More research, though, is really needed to understand exactly what type of counseling from health workers in different circumstances can make the highest impact on violence and how to measure that. We're actually testing out a multi-sectoral version of care groups right now, the Nurturing Care Groups project model in Ghana that's just getting underway. And as part of that, we're promoting WASH behaviors, but also child protection behaviors largely centering around positive parenting. So we think this is one thing that could be quite easy to integrate in with some of our current models. 3 stakeholder types were more commonly cited as being the most influential, either positively or negatively. So on this graph, you see some of them go down in terms of the disapproval as in of VAC response is in red, and the disapproval of violence against children prevention is shown in a deep green there below the line. And then the other 2 lighter green and lighter red bars are for those who approve. And so 3 stakeholders were mentioned more commonly for both of those in terms of community health workers' involvement and prevention and response work on violence against children. Community leaders, government workers, and parents of children. But note that there are higher percentages of community health workers who mention people who do support or would support community health worker involvement in violence against children prevention and response than the percentages who would disapprove of that. So we need to socialize this idea in communities, but there's already a lot of support, at least from the community health workers' point of view. They perceive there's a lot of support for them getting more involved here. And so that's good. We did ask about barriers, which you'd expect from the person who created barrier analysis. And we actually used some of the questions used in barrier analysis to explore this a bit more. We'll be evaluating that to see if there's certain determinants, basically, amongst the promoters that meant that they would be more likely to intervene. But when we ask about barriers overall, they mentioned, 56% mentioned that they weren't trained in this area, even though they're still working on it. 38% mentioned lack of community support. 32% mentioned lack of personal motivation. 30% mentioned inadequate transportation. 22% mentioned possible non-cooperation of victims or families, and only 13% mentioned lack of personal security as a barrier, which that last one is one that a lot of people thought was going to be the main barrier to working with them. They'd say, look, this is just too dangerous. You're getting involved with, violence. No, they didn't feel that. They're able to manage those sort of relationships with the people that they serve, it looks like. So any future interventions geared to strengthen the role of community health workers in ending violence against children will really need to carefully consider how to lower these barriers and influence the influencers, as they can make it harder or easier for community health workers to intervene in this area. Some of these barriers that are shown here may be easily overcome by targeted investments of governments, NGOs, partners, things like lack of training and inadequate transportation. But it'll be essential to generate community support by community leaders, faith leaders, government workers, and parents, so that community health workers can safely and optimally engage in violence prevention response. Even though only 13% mention personal security, I do think, given the rising violence against health workers we're seeing in some areas, that we need to make sure they're best prepared for that and they have the community support they need to intervene in this area. So our main conclusions from this research are that community health workers are already detecting hidden violence, and they can assist with data collection on violence against children. They're already responding to violence, and they could do more and do it better with proper training and supervisory support. Community health workers' work to end violence against children needs to be linked with community-based child protection structures that include the community health workers themselves. And support by community leaders, government workers, parents, and faith leaders can be a key enabler for community health workers' safe engagement in ending violence. In terms of our next steps, we plan to publish a series of papers in the coming month. We also have a summary of our research report that's available online. We'll show you a link to that. And we will be hosting a series of technical roundtables and discussions with partners externally, including this one today, but also with the WHO, the core group, the Global Partnership to End Violence, and all of that in order to inform policy and programmatic choices by World Vision and other organizations and governments. We think this can really help develop some evidence in this area and help us move forward. So lastly, Elena, if you want to unmute and go through some of these resources and tell people a little bit about the It Takes a World campaign, and I can advance the slides for you.
Thank you, Tom. Hi, everybody. Lovely to see you on this webinar, and we look forward to your questions. This is just a list of key resources that may be useful. First of all, the link to our global campaign, It Takes a World to End Violence Against Children. This is the campaign under which this study was commissioned. We also work as World Vision with other partners because, as our campaign name says, we cannot end violence alone. It takes every sector, it takes everyone. That's what we believe in. So we work hand in hand with the Global Partnership to End Violence Against Children because this is the global platform that brings together the efforts of everyone, governments, UN agencies, civil society, academics, and children, faith leaders to really end this phenomenon. So I'll invite you as well to go there, and you'll see a few resources that can be useful. The Inspire package is the 7 strategies to end violence against children that most of the global agencies led by WHO and the World Bank, but with the signing up by UNICEF and many other CDC, they have put together this package of evidence-based strategies that are proven with, randomized control trial style evaluation to have worked in preventing and ending violence. And there you'll find, a package of information that you can use, and includes also all the health sector-based interventions. And finally, some additional resources on ending violence against children through the health sector and community health workers from our own programming. Tom briefly mentioned that there's quite a lot that World Vision has done over the years to to develop our parenting programs, in particular what we call timed and targeted counseling. And there's some new curriculum that has been developed and really includes a lot of child protection activities into the training of CHWs, and it could be interesting for you. Maybe just one couple of words, Tom, if you can move to the next slide on our global campaign. just for for your information and to keep this in a bigger perspective, our global campaign in which I work is running from 2017 until 2021. It's a 5-year global campaign that really tries to contribute to ending this phenomenon of violence by making a significant contribution in 4 areas mostly. We want to ignite a movement. We want to catalyze global changes in attitudes and raise awareness, because we know the violence is very much about attitudes, and changing those attitudes is key to changing then the behaviors. Tom is an expert on that, so we are lucky to be working with him on this. We want to strengthen the services, both prevention and response, because we want governments to be accountable for the services they provide, and we want NGOs like ours to also improve the quality of the services we provide where governments are leaving people behind. We want to increase funding to the issue. We know that this issue is underfunded. In the health sector, for example, there is limited training for health workers on this issue. We saw it in this survey. So we want to advocate for the funding to go to really what can make the biggest difference for children on the ground and protect them closest to where they live, which is also where, unfortunately, they are most at risk. And finally, we want to strengthen accountability. We want those who have made commitments, including in the health sector, to deliver on those commitments. And what we're hoping to do and what we're trying to do in the campaign is really to do it in a multi-sectoral approach, bringing the sectors together, the health sector, the livelihoods, education, humanitarian operations. It's our vision is that it has to end as a phenomenon, violence, through the efforts of all of us together, and that's the only way in which we can do it. And very, very important for us, the drivers that you can see on the slide, we want to put children at the center. We want to work hand in hand with our faith partners and put really faith at the center, because a lot of the times, there is also faith justification to some forms of violence, but we know that on the other hand, faith is one of the biggest ways in which we can solve the problem, is to really harness that power of faith and sacred texts and theological resources. So there's a lot that we're doing on that, and I'm happy to answer questions on this. Thank you. Over.
Thank you, Elena. I'll go ahead and stop sharing my slides now then.
Okay, thank you very much, Tom. Thank you very much, Elena. It's great to hear this. We hope that you will share some questions. We haven't seen any questions come through yet, so in the meantime, as we're waiting on you to type in your questions, I'm going to go ahead and start. And being an academic type like I am, I'm curious, Tom, about who the community health workers actually were that participated in your study. Were they World Vision related community health workers? Were they employed by NGOs? Were they mostly women? Can you give me a sense of who the people were who participated in your study?
Sure. And that one of the things I've loved, I've been working with World Vision almost 2 years now. And I remember I was excited when I came to World Vision and saw that we're working with 220,000 community health workers. So almost, 10% of them. And with this particular study, we had a big project called Enrich that is working on nutrition and maternal mortality in those 4 countries. And so I was involved with the midterm of that project. And when we came up with this idea, Elena and others in our office here, I realized we don't have a budget for this. It's already after the beginning of the fiscal year. And so one reason that we decided to do the work in those 4 countries is we thought we could piggyback it on what they were doing, especially since that work is being paid for by the Canadian government. And they are very interested in gender issues and issues around violence. And so we got their approval and basically formed the questionnaire, did some training online with them and some in person. And then basically we had our project staff going out to interview the community health workers that were working with us in that project. And they're government community health workers, but ones that we had been partnering with for this other work that we were doing.
Okay, very good, great. Okay, we have a couple of questions coming in now. Great to see them. So Marge Docking has asked, is there good training packages for community health workers available, or is that something that is still needed? So I think you may have alluded to some of that already, but it'd be good to hear a little bit more about it.
Yeah, Elena, if you maybe want to start with some of those particular materials that you talked about, and I can add on.
Yes, absolutely. Thank you for the question. We have what we call one of the project models that World Vision has developed over the past years. It's called timed and targeted counseling. This is, was born out of maternal and child health objectives and our work on that. But it gradually expanded into what we call plus. So looking at really what can the community health workers provide in terms of counseling, information, parental care practices in other areas of child well-being that, as Tom was saying at the beginning of the presentation, ultimately affect as well the health outcomes. So we have this training, which is one of the resources that was I linked in the slide. So when you receive the presentation, you can click on it. It's all available online. And there's training materials for different parts. And it's really interesting because, they have even developed cards. For example, if you look through it, and we can send you, if you're interested, more materials. They developed comics, stories, so that, the whole theme of violence can be treated in a very context-appropriate way, in a very, more funny, more engaging way, because it's always difficult to discuss this issue. So everything has been tested. There's I think Ghana, there's some work in Senegal, there's some work in Haiti as well. So it's been tested in several places. I think we also have it in French because of Haiti. So yes, we do have some materials, but I believe more can be done. Tom, you want to talk about that?
That's especially in the second edition. We had a link for the first and the second edition. I think most of that's in the second edition. Is that right? Right.
Yes, correct.
So we have the timed and targeted counseling, which is great. I just saw some of our work in that in Kenya, where you're basically visiting pregnant mothers and mothers of kids under 2 about 9 or 10 times during that period through home visits, using positive and negative stories. And in addition, we are using the care group approach and this more expansive version of the nurturing care group approach, which includes promotion of behaviors around not just health, nutrition, and wash, the traditional focus, but also education and child protection. And we're developing the curricula. We have the training manual, a draft training manual developed, but the curricula for it we're doing progressively. And we have 6 lessons that mainly focus on positive parenting that we can make available to people too. We did it in conjunction with Asparian Health Guides. And one reason I wanted to do that is keep it in the public space. And so we just asked people to, if you put your logo on it, keep the other logos that are already on it, but you could use those materials as well.
Okay, that's great. Thank you so much, Tom and Elena. So we now have a question from Amy Wilson. Thank you, Amy. Do you need resources for the restoration phase of children once violence has occurred? Our organization, which is a CCIH member, offers that if so. So we don't know what your organization is. Amy, it'd be good for you to share that with us. But any comments from Tom and Elena?
Yeah, no, that's very good to know, because we've mainly focused on we're thinking we're going to go a bit progressive, and what we'd really like to do is have community health workers all know how to properly promote things like positive parenting, and then we start moving into the referral and legislative areas of this. But for now, it's like a lot of parents sometimes don't know what to do with children. They haven't been taught different ways. So I want to make sure that we're actually leading with some of the prevention and giving parents skills to avoid violence against children. But I do think recovery of children that have been severely abused, that will be very important. The WHO actually is coming out also. I think it's more on the detection, identification of children who have been sexually exploited for primary healthcare workers. And Elena, I don't know if you've heard any more from our colleagues at WHO about when that guidance is going to be coming out, but earlier they were saying sometime in fall they had hoped to roll that out and to pilot it.
Yeah, I think they're going to wait until the issuing of the next global report on ending violence against children. Usually the WHO issues a regular report on violence. This time it will be only about violence against children. They were supposed to release it in the autumn this year, but it will be until spring next year. So I'm assuming they will deliver the guidance as well at the same time.
Perfect. Thank you.
Okay, great. And I see Amy has shared with us the name of her organization, Crisis Care Training International. So Amy, thanks for that. Okay, well, let's go on. We've got more questions, which is great. Aishola Abdul Razak is a child protection officer at Save the Children and has a question with regards to the study. She says that in Nigeria, community health workers will always tell you they lack the financial and resource capacity to respond or prevent violence against children. How do we engage our government in terms of policies and resources to engage these frontliners, the community health workers, to be able to respond and prevent violence against children? Tough question.
Yeah, and I have a feeling it goes way beyond ending violence against children, right? That we're hearing all over the place that they're trying to put more and more things on top of community health workers in terms of tasks. And I just heard someone from he was one of the cabinet officials for public health in Kenya talking at the core group conference in Nairobi. And he was saying he was very impressed with what Ethiopia had done in that regard. And I think that is part of the solution, that we should have paid professional community health workers who are working full time. And then working with them, we should have community health volunteers who are mainly focused on behavior promotion. And they should work no more than about 8 to 10 hours a week. We should take advantage of the fact that we have volunteers that can do this work, and some of the excellent gains we've seen and changes in health status using volunteers. But it can't stop there. And I do agree that the best situation is to have one paid community health worker working with a couple of groups of volunteers to be able to expand what they can do and do some task shifting. Because when community health workers say we really need to be paid if we're going to do this, it is just overall is part of the problem is we're asking them to cover too many households and do too much work when they're often working as volunteers or getting very small stipends.
Okay, great. Thanks a lot. So Paul Fast has expressed appreciation for your presentation. He wants to know, what types of violence do you feel community health workers are potentially most and least well placed to address effectively?
Elena, I don't know if you want to take that one.
I can take it. Thank you. Thank you. Great questions. I think in my view, and that's also, I would say, confirmed by the prevalence that it's reported by this survey, the home-based type of violence is the easiest one for the most relevant for the community health workers to address. So corporal punishment, child marriage, sexual violence that may happen, within the family or the community, because these are all areas where the community health workers can detect by visiting, and they can also provide resources for the mother and the father to protect better the child, or to discipline them using positive discipline tools rather than abusive verbal and physical manners. Other forms that are less easier and less relevant, I would say trafficking. I don't see very much the role of community health workers in dealing with trafficking, because trafficking is often involves, cross-border movements of children. It involves, international police and other, other service providers are better placed. Although if there is sexual abuse involved in that trafficking, of course, then community health workers could be able to detect, for example, if a child is being abused, or a child who does not belong to the household, for example, is now living in a different household. But I would say that it's very, it's minimal. I would say more facility-based healthcare would be more relevant in those cases. In terms of child labor, I was surprised by the numbers that we saw in the survey, because of course child labor, most of it today happens at the family level in agriculture. That's where the highest rates are, informal agriculture. And, is there a role for community health workers there? Again, this is a complex problem. It has to do with poverty. It has to do with, not just parenting. And therefore, maybe in detection, yes, because the community health worker may be able to detect if the child is very tired or has a lot of injuries from working, for example, in cocoa harvesting, which is done with machetes and very, dangerous utensils. But then, in terms of prevention, I don't see them. So yeah, I think the kind of more family-based forms are the ones where we have, and they are also the ones that are driving those numbers. So the 1.7 billion children statistics is actually driven by 1 billion of children who are victims of corporal punishment, which is done in their household. So that is where we can really, if community health workers can help with that, that would lower the number significantly, and that's a significant gain.
Yeah.
Great.
And also when we say community health workers, it's not them working independently all the time, of course, but in conjunction with like child protection groups, because to change those larger community norms around this, work at the household is essential, but also having worked with faith leaders, with community leaders, that can really change the game and do it a lot more quickly and better.
Great. Let me expand on that question just a second, because I'm wondering in terms of what kinds of issues can be best addressed by community health workers. In your study, were most of the community health workers women? And can you say just a few comments about the value of gender in addressing these issues, either positive or negative, whether the community health worker is a man or a woman? Any of those issues come out in your study?
I can talk to that if you want, Tom.
Yeah, I don't remember from their data set what percentage were male and female.
Yeah, I can tell you because I have the full paper in front of me. So we had 50% of respondents were female. 55. So we had 55 female, the rest male. Of these, of all the 412, 99% were literate. Mean age of 37 years old and 9.5 years of schooling. Yeah, that's the background. Now, we did try to analyze if perceptions of prevalence and other perceptions, responses to violence, all the statistics that Tom presented. We did try to run some statistics to see if the gender of the community health worker had an influence. Surprisingly, the only variable that had an influence was the age of the community health worker. So younger community health workers, which in this study meant below 35, I believe. Yes, it's these community health workers that were younger significantly reported there was a significant, statistically significant association with them reporting that they have seen violence against children, different forms, and that they think these forms are very serious and therefore, not acceptable. And also they are more likely to provide support. So it seems that the real game changer here is that maybe we should work with the new generation of community health workers because they seem to be more
right. Well, that's great. And another question I wanted to ask, which you were kind of approaching a little bit, but while we're on this, let me jump in and ask it, taking the privilege of the chair, so to speak. What about looking at this by different countries? Were they all pretty much the same, or were there some marked differences country by country?
And I think I mentioned that Kenya, there was some variation between Kenya and the two Asian countries in terms of them. Was it more likely to intervene? I'm trying to remember on that one, Elena. And that you have the paper in front of you, so you might want to point out some of the other ones.
So there were differences in the prevalence, but for that we can send you the detailed paper where you can see the different, prevalence, which is more mirroring what the surveys like MIX or, DHS already shows us. But on the response, which is kind of the novelty of this survey, the Kenyan community health workers were most likely to respond, while Bangladesh and Myanmar less likely to respond.
Respond to violence.
Respond to observe the cases of forms of violence against children.
Yeah.
And are you saying that the demographic and health surveys have questions along this? I knew there were questions related to violence against women, but there are also questions about violence against children.
They have questions on the prevalence, yes. Actually, that's where most of the data on prevalence comes from MICS. There are modules on child protection. They don't ask all the questions, but they ask significant questions about sexual abuse, child marriage, child labor, and corporal punishment.
Yeah, so the mix, for those of you who don't know, is the UNICEF survey, multiple indicator cluster survey, I guess.
Yeah.
Okay, great. Okay, that's wonderful. Thanks. So now, great to see a question here from Ray Martin. Hi, Ray. Do you have experience yet or ideas on how to use religious leaders, pastors, imams to change attitudes important to reducing the level of violence against children?
Yes, and in fact, I was just looking at some of the different work that's been done around that. Elena, you might be able to summarize this a lot better than me, but I know that we've been using our Channels of Hope model to start talking about violence against children. And in some areas we've seen by engaging faith leaders as well, we could lower child marriage.
So yeah, we have evidence at all levels. At the programmatic level, we are at the moment conducting, other colleagues, not Tom and I specifically, but World Vision is conducting an evaluation of its work with Channels of Hope. It's a project model based on engaging faith leaders at the community level in a process of transformation where, attitudes and behaviors, and there's a question on that later on, are being changed. And then these faith leaders then help the communities change the entire, view of the child and the view of women in cases. So this model has been applied to child protection issues and in particular child marriage. So we are evaluating in Senegal, for example, what has been the impact on that. I think it's with Johns Hopkins, actually, your university, Henry. But yeah, there's some major universities involved in that, so that it's an independent study. They are also looking in Latin America, so we have 2 different countries to compare. That's going to come out soon. The evidence on that we'll be happy to share with you. We also have some collaboration with a hub that has been created. It's the JLI, a Joint Learning Initiative. It's a hub that has been existing on other topics where there is research and advocacy going on about the role of faith actors in development issues. And a new hub on ending violence against children was created with World Vision 2 years ago, and there have been 2 studies that may be of interest to this audience. One is a study on the role of faith actors in ending violence against children on the move. And then there's a second study which was just published in June on really looking at what is the available evidence on faith actors ending violence against children in all its forms. And so there you'll see a range of functions from providing services, in some cases the churches are providing services when there's nobody else, and to advocacy and changing, decision makers' position. So there's a whole spectrum in which faith actors really can be harnessed from the very low level at community to, changing policies and influencing global decision makers. So we'll be happy to make those available to all of you.
Let me add on to that. There's a 2016 study that World Vision did around social norms change called Protecting Children from the Harmful Traditional Practice of Early Marriage in Uganda and Nepal. Dr. Philip Cook, Rebecca Nellums at IICRD, and Dr. Mike Wessels, Columbia University for World Vision were involved in that. And that did include working with faith leaders, multi-faith leaders to address the issue. World Vision has been successful in implementing this Channels of Hope model we have for child protection with multi-faith leaders from Hindu, Buddhist, Islamic, and Christian faith communities. And the faith leaders basically become advocates for child rights and protection. We're able to educate children and parents and community people on the issues of child protection and ending violence against children. And in this study, the results were, there's an independent study on the role of social norms change in changing harmful practices. In Nepal, they experienced a 70 to 80% drop in the prevalence of child marriage. So I found that rather remarkable, just how much you could actually reduce something that we often consider as a kind of unmovable cultural thing that much in very little time by having this whole of community engagement, mainly with working through community, the pastors and the other faith leaders in these countries, and by also working with child protection groups.
Okay, great. Thank you so much. Let's go to Mary DeCoster's question now. Hi, Mary. Elena mentioned that attitude is an important factor in violence prevention. I think behaviorally, it's a bit more complex than attitude. People need training in alternatives to violence, such as nonviolent communication skills. I'm also reading a book called Willpower by Kelly McGonigal, and I'm reminded that mental bandwidth as well as mindset are also an important factor in family violence. People aren't their best selves when stressed and exhausted, but making new behaviors habitual reduces the burden on the frontal cortex of your brain. Any thoughts?
Oh, that's excellent, Mary. I'd love to talk with you more about that. As you know, I mean, both Mary and I worked on a study looking at what sort of changes you get in terms of child well-being, especially health and nutrition outcomes, when you treat mothers for depression and caregivers for caregiver depression. And we just finished that research in Uganda. Food for the Hungry was the lead on that, and World Vision was involved, Columbia University and Hopkins. And we saw 23 points better adoption of these behaviors amongst women who were no longer depressed versus the depressed moms. And so I have no doubt that mental health is also a big piece of this. And I think we should begin starting to really measure some of the outcomes from things like interpersonal psychotherapy for groups, IPTG, but also Problem Management Plus and the Thinking Healthy model. All three of those are endorsed by the WHO. And they're brief. You know, I think Problem Management Plus is like 5 home visits is all it takes. IPDG is about 12 group meetings. So there are things that we can be doing to reduce depression and improve overall mental health in caregivers. And I think we need to be measuring along the way what sort of results we're having in terms of violence against children. And Elena, I'm trying to remember if the Problem Management Plus research that we did in Kenya, if they actually saw outcomes in terms of improvements in how people treated their children.
I only remember a study from Peru, which unfortunately didn't show any change in positive parenting, for instance.
Oh, okay. Yeah.
So yeah, it's not always a straight line.
Yeah, it
as
isn't.
other people have said in the comments. So
Yeah.
very true. What I want to point out is also that sometimes, yeah, we don't need to reinvent the wheel on some of these indicators you were asking, because yeah, it's quite the surveys, the mix, the multiple indicator cluster surveys of UNICEF, the violence against children surveys that are, you know, originally developed by CDC and run by Together for Girls. They have a lot of questions that already capture very specific behavioral indicators about that measure how parents, for example, treat their children. So these are very well tested around, you know, the globe, and you can start from there and maybe include some of the same questions in, you know, surveys or evaluation of programmatic approaches as relevant.
Okay, great. Marge has another question here. She wants to know how in your survey you defined children. Was there a specific age group that constituted the upper age for the children that are being referred to in the questions?
We usually use 0 to 18 for when we're talking about children. But Elena, for this study, was it also 0 to 18?
Yeah. Yes.
Okay, 0 to 18.
So it was also the adolescents in the
Okay.
household, not just the babies that usually a community health worker would, you know,
sure.
Cater to.
Sure. Okay. Aishola has another question. She says it's a rider to the answer you had given on strategies we use to impact this study. Humanitarian response is a short response and as well has a short lifespan at most 2 years. Planning for a sustainability strategy and continuity is important. We have volunteers already working for us, and we can have one working directly as a community health worker. How do we sustain this kind of movement?
I'm not sure I totally grasp that.
Yeah, I'm not sure I do either, but I guess your question has to do with sustaining the engagement over a longer period of time? How do we motivate community health workers to stay involved in this beyond just the acute crisis, I guess?
Yeah, well, actually, I've got a whole narrated presentation. Maybe we could send the link on that. Remember back a ways with APHA, Henry, where we're talking about motivation of community health workers. And definitely there's been quite a bit of study around that, and looking at especially the using non-financial motivations such as respect, recognition for their work, a good supervision. These are all things that are motivating to people. And we've seen with large systems of volunteers that when you provide those non-monetary incentives, you can get dropout rates of less than 5% a year. When people reach a certain level of work, as I said, I think we do need to pay them if we expect them to be motivated. But let's be careful too about crowding out of those intrinsic motivations of helping one's neighbor and the sort of respect you give. Because we have also seen places where they started offering small incentives, like paid incentives to community health volunteers. And suddenly all the mothers are saying, hey, I'm coming in the meeting. Why aren't you paying me? And what's going on? How much are you actually paying this person? They said it was this amount. And there can just be all these jealousies that come up as well. So I believe in making sure that those incentives are not crowding out some of those intrinsic motivations people have from their faith and from other areas.
Yeah, great. Okay, thanks, Tom. Now we have a question from Ramatu Kargbo from Save the Children in Sierra Leone. Great to have you, Ramatu. He says, in my context, the social workers who are attached to the Ministry of Social Welfare or to NGOs are closer to communities than the community health workers. How can we improve linkages among the various sectors? And can the research findings be applied to community social workers?
I don't think the research findings could. It could be a different sort of relationship they have, but I don't think we definitely shouldn't be limiting our view of who can actually help with this to community health workers. It's just since we have so many community health workers out there, we think that they should be used. But in places where you have other cadres, perfect. You know, we should engage them as well and probably do the same sort of research to find out to what degree are they already engaging in this? Could they engage? Are they properly trained already on it? It would be really good to know that as well, I think.
Okay. Can I add on this?
Sure,
I think it's an excellent question, Ramatu. And as you know, probably just like Save the Children, World Vision uses a systems approach to child protection. And we are really investing a lot in child protection, community-based child protection mechanisms and structures where communities self-organize around, child protection issues, and where they have social workers. Those are a key part of that. The reality is that in many countries, there are low-income countries, there are no social workers at the local level. Sierra Leone may be an exception. World Vision, I believe, I don't think we work there. And therefore, it's if it makes sense, because those are the ones that are more present at the community level, then I definitely support what Tom was saying. This type of survey can be really applied to those workers, because they can, in turn, not only take care of the social issues, but also perhaps link better to the health teams to refer cases of health that, were not picked up. So I think the transformation works when we are working both ways, when the health sector helps achieve other social goals, but at the same time, the social sector helps achieve health goals, because that's where we gain, together, and we can make a stronger case that there is an investment needed at the community level on both sides.
Yeah, and in terms of integrating that multi-sectoral integration, one thing to keep in mind is this nurturing care framework that was released last year by WHO, UNICEF, and World Bank. Right in that, it says one of the key components is safety and security. So a lot of our work in child protection can be framed in that way. So as governments are urging, with localization, obviously it needs to spread all the way out in a lot of countries. But even in Kenya, I saw that they were doing quite a bit at the local level to say we need to get on board with this nurturing care framework, and that includes things like caregiver depression, child protection, early child development. And so it's a good vehicle in a way to say we should push for this framework, which has international buy-in and buy-in of so many governments. This is a way to move it forward as well.
Okay, so it's almost 10 o'clock our time locally. Our hour is almost up. We have one more question here from Grace Tazalar. Thank you, Grace. Do you know of any projects in the U.S. using community health workers? I presume you want to ask with respect to prevention of violence against children.
I don't. Henry, I don't know if your work with community health workers expanded to include both CHWs in the U.S. as well, or maybe someone else on the call as well.
Yeah, I myself don't know of any projects or programs that are directed against this specifically. So
Now,
but there's the home visiting nurses, so I don't think we can qualify them as community health workers, but the function is similar, right?
yeah, no, I was going to say in the UK, there's been some good research around that where they found that home visitors were able to intervene for at-risk children and help actually change parents' kind of narrative about the child, because often what they would hear from parents who were more likely to abuse children is that that child's just trying me today and he knows I just keeps screaming at me, and almost this kind of antagonism against the child. And so they would work on helping parents to understand why do children cry, how can you soothe the child, and just having that home visitor in the house. There's some evidence that can really do a lot to help reduce some forms of violence.
right. Okay, well, our time is up. This has been a very exciting session, and it has helped me again to appreciate what I call community-oriented public health, which is how can we work with communities to help them improve their health. It's one of the great frontiers of public health, and I'm so happy to be able to work in this space. And I think we're all indebted to World Vision and to its leaders and to Tom and Elena for sharing with us today what they've done. And we hope this has been a stimulation to you and help open up some new ideas and thoughts for how you yourselves might be able to engage in this important issue. So thank you so much, and we hope you have a good day, and we look forward to having you join us on another webinar.
Thanks, everyone.
Thank you, Henry.
Thank you.